So for the next presentation, I welcome Dr. David Erritzoe today. He's going to present on psilocybin and DMT for depression. He's a clinical director and senior clinical lecturer at Imperial College London, and he's particularly interested in psychopharmacological research using brain imaging techniques as PET and fMRI. As the clinical director and deputy head in the Center of Psychedelic Research, he investigates mechanisms and the therapeutic potential of classical and non-classical psychedelics. So I look forward to your talk today, David, and I would ask you to please sit down.
Thanks a lot. Yeah, there's a little bit of in and out, which is fair enough. Makes it complicated logistically. So if people, I don't know how many from this conference also went to Denver. So my talk, because as much as we would like to have a new study ready within a couple of months, it's not that it's going to be particularly different. So if you actually saw me present on depression in Denver, then maybe also run out and see something else, because it will be a bit similar. So thanks a lot for the invitation and the introduction from Laura, who used to work with us at Imperial and who is part of some of the work that I hope to get to as well. So basically, the not surprising, familiar to people, this is a slide from Small Pharma that we collaborate with for the DMT work with depression, that one of the reasons why depression has been in focus for the development of classic psychedelics is that it is such a impactful, with incredible negative impact on so many people, and particularly that not much has happened since the 80s, where fluoxetine, the first SSRI, came through. Then you have had sort of modifications over the same recipe for development of drugs for depression, and there's still a big chunk, around 40%, who don't respond to the current SSRI model. And that's not even what's written on the slide. You have the financial reasons why it's important to focus on depression. You also can see down the bottom right that 1 out of 8 who recover from an episode of depression remain depression-free. So there's a big demand, a big need to develop treatment. So that's one of the reasons. Another reason is that you have had Johns Hopkins and I think early on Usona, who were sort of focusing on end of life, which is a beautiful and meaningful indication for psychedelics, but sort of had to sort of transition over towards depression in order to sort of satisfy the system, funding bodies, and so on, because you need to go for a formally approved and recognized diagnosis as an indication for development. So therefore, in a way, it was also moved over towards depression. So a few different reasons. In terms of what we have at Imperial in London been doing, a lot of you will know that Robin Card-Harris, he was sort of leading these 2 depression studies, but obviously a lot of people in the team involved, and we did an open label feasibility pilot. That's kind of overlapping terms for the same thing. So a kind of crappy little study scientifically, where you don't have any control conditions. You're just testing whether it's possible, whether it's safe, and how people tolerate a psychedelic. And the reason why we did that was actually the first study in the modern era of psychedelics for depression with any psychedelic intervention. So that was psilocybin, 25 milligram, in quite severe depressed patients, 18 out of the 20 severely depressed, and 2 of them moderately depressed. These are the data that people will probably have seen many times, with the bold bar representing the average of the depression severity. The primary outcome was here at 1 week, but we follow people for 6 months. And this initiated a lot of optimism and enthusiasm, and also played some role in some of these companies starting up early on after these data. Not just because of these data. The reason why we did that was obviously building on the shoulders of work done in the first era in the 50s, 60s, where a lot of depression work was actually done with both LSD and psilocybin, and also other data pointing in the direction as well. So that one was the first one. Then we thought, okay, how can we make a better one? And the idea was, logically, because it's difficult to placebo control, that's been clear for many decades, you could then test maybe different doses. So 1 milligram, 10 milligram, and then the full 25. That was then what Compass Pathways went with. So therefore, we were like, then we should look at some other mechanistic work instead, where we also have some strength with imaging and so on, and therefore instead designed a trial where we compared the psilocybin to a conventional state-of-the-art SSRI treatment, escitalopram, which is a very selective serotonergic drug, so kind of a fair one to compare to, and also performing well both in terms of efficacy and tolerability compared to other SSRIs. So that was the one. And then we did 2 sessions of psilocybin with 3 weeks between, and here we did 6 weeks daily escitalopram. Here they also got 2 placebo sessions with psilocybin in a tiny 1 milligram dose, and here they got placebo daily capsules. And then, so they were exposed to the same in the 2 arms as well as we could in this design. And that was also published a couple of years ago. So those were the 2 depression trials in terms of in terms of the escitalopram trial, the second one, with also more subjects. I'll get into the results in a second, but before, obviously, always important to mention that it's not just the pharmacology, it is the combination of the pharmacology and the context. So the therapist in the room, the preparation, support, guiding, integration after, the music, the setting, everything that sits around the actual drug is also part of it. But remember that people went through this treatment setting, not this specific one, but in both of the arms, right? So in the placebo sessions, they also went through that in that trial. So the results are here. You might also have seen this before. Things that are green and to the left of the dotted line, that is in favor of psilocybin condition compared to the escitalopram condition. And that basically was the case for most scales. You see here that there are 4 different depression scales. 2 are clinician-rated, 2 are self-rated. And QIDS was the predefined primary outcome. And what we see is that Brandon Wise, a postdoc in our lab who now moved to Johns Hopkins, he did a nice analysis where he did factor analysis from the different depression measures, and when you do that, it clearly separates, whereas the QIDS on its own didn't separate. And there's a lot of reasons, nicely discussed by Brandon in that paper, of why that might be, that it differed. But basically, you can see that most scales favor the psilocybin condition, also other scales that I will touch a bit upon. We also see sustained effect after 6 months. We are coming out with that paper. We saw that in both of the arms, with no obvious explanations for the difference between the 2 groups, but that they were kind of similar, didn't differ in terms of depression measures. And that was, again, QIDS. That was the only measure we had at 6 months. It would have been interesting to have some of the others now that they actually differed at the early time point. And then we could see that expectancy didn't predict this response to psilocybin. That's kind of reassuring, maybe even a bit surprising, but it did predict for SSRI. So the more you expected your escitalopram to have an antidepressant effect in this trial, the more it did. Was not the case for psilocybin. Whereas suggestibility, the more suggestible people were, the more effect it had with psilocybin. And then some interesting psychological elements. We see reduced rumination and thought depression specifically for the psilocybin. So more of that, and not for psilocybin, not for escitalopram. Reduction in experiential avoidance, which is an important psychological factor in a lot of mental health. We saw reductions there. And we also saw measures of enhanced emotionality, ability to cry and feel emotions. That was increased in the psilocybin arm, which is interesting because one thing is you have the depression measures. You also have quite interesting psychological associated factors that then really, really look like they're separating the 2 different treatment modalities. You see, where you can have blunting and sort of emotional blunting, where you have sort of a lid on your ability to feel yourself, feel emotions. That is a side effect for some people, for SSRIs. You see an enhancement of that ability in psilocybin. So that's probably quite an important distinguish potentially between the 2 different kinds of treatments. Also enhanced sexual function, speaking to the same thing, actually. And then I think I won't go into this about discontinuation. The Compass didn't see the same, so it might be a bit too much and confusing to go too much into, but we are coming out with a paper on that soon as well. Basically, this was some of what Matthias was just talking about, that his team, they have seen, that he just showed you before, that pre-treatment with SSRI for a couple of weeks in healthy didn't affect. He also showed the Compass data suggesting the same thing, that it doesn't really matter that you're on an SSRI. But, and also MAPS have been looking at, and Matthias also said that it does matter with an SSRI if you are treated with MDMA. So therefore, either the MAPS with their MDMA either need to then pause or maybe test out whether it's meaningful, safe, and give response to give higher doses of the MDMA if people stay on an SSRI. Also what Matthias was alluding to. But what we have survey data, we don't have trial data for being on an SSRI and being treated with psilocybin, but we have data from our surveys, and when we look at that, we actually see something that is not in agreement with the work that Compass and Matthias are doing. And remember, they are controlled trials, so they are stronger evidence. But when we look at the survey data, which is real-world prospective data, people who reported that they were going to stay on an SSRI, they had a blunted response when we measure, we assess by online scales their altered state, mystical type experience. You see that when you look at the MEQs, or mystical or challenging or emotional breakthrough, you see a reduction in a lower experience measure in people who stayed on the SSRI compared to people who didn't. And that's a little bit interesting. It's also interesting because we don't see any difference and any reduction in visual, and that speaks to maybe there's some degree of emotional blunting from the SSRI that then prevents you from having a full experience. That's what this suggests, but that is in discrepancy with what Matthias was showing. So jury is still out. Yeah, and that Matthias also mentioned they're doing 6 weeks with LSD, which is important. Basically, a little bit of a sort of a summary. So I've just last night exchanged Compass data with Usona's data, because now Usona is the most late and they're all interesting, but no, I don't want to start saying the one company is more interesting than the other, then we'd be in trouble. But I mean, we are collaborating with both because we receive their compounds for our trials. But basically, when you look at depression work overall, there's several trials, and when you try to get an overview of the effect sizes, you can either do that within subjects, so before to after, if there's no control condition or control group, or you can do it between group. And no matter which of the ones you look at, so far the effect sizes look like they're a little bit better than what you see with conventional SSRI, or for that matter, talking therapy. So that's the sort of main thing. And what I was going to say, actually, in parallel right now, in another session, I think Usona, Rayson, they are presenting this. So now, because you're missing that, then you have it here. Then you get a super short version, which is basically these two graphs, which shows it works great, basically. So they did 104, either niacin or psilocybin 25. Simple design and solid response, and also sustained response up to 43 days. That's basically what I think they will be talking about downstairs as well. Great. So I'm then jumping into the work that Small Pharma, London-based, that might just have been purchased by another company. They have been doing this trial with, I was acting as the chief investigator, so we had a role in the trial. What they did was we randomized 34 patients to, so 17 versus 17. So they either got placebo infusion or DMT infusion, and these were people with depression, some of them even fulfilling criteria for treatment resistance, but not necessarily all, but pretty severely depressed patients. So 2 arms, and then they were followed for 2 weeks. And at 2 weeks, then they could get another dose, and that the blinding at that point was broken, so that was an open label phase from that time point. And this is some demographics. They were this age in the two groups, so early 30s and more male than female, which is a bit odd in a depression study, but a bit of a classic problem because males seek more this novel stuff, novelty-seeking thing typically, so it's a bit difficult to get enough women in some of these trials, unfortunately. Efforts were made. And they were quite severely depressed, as I mentioned. And then what you see here is that the placebo people, so this is the first 2 weeks where they were randomized and blinded as well as you can. Then they had a minus 3.6 on the MADRS, which is a conventional clinician-rated depression rating tool. And then you had a larger decrease here. So a bit similar to what you just saw in the Usona psilocybin and Compass psilocybin. Basically what we saw here with DMT. Then this is what you just saw before. This is the first phase here. Then this is after the 2 weeks. Then they get another dose. So the people who had placebo get their first DMT dose, and the people who were in the DMT arm, they get their second DMT. And then you see that the people in the placebo arm drop down in their depression severity, which would be expected if it works. And so comforting data, and also sustained response at 3 months. And we also have sustained response in most people at 6 months that I'm not showing here. And here are response and remission rates quite strong, around 50%. And it doesn't seem to be an issue whether people got 1 or 2 doses of DMT. It could also be that they were a bit too close in time. I think this is just a little summary. I can share some of these slides in a PDF to the conference, like Matthias did, I'm sure. And then this thing about, what about the acute experience? How the actual subjective experience relates to the therapeutic outcome? This is somebody who did a nice overview of trying to see how many trials are finding what. So there's a bit mixed data, but overall positive, and there are more data also finding positive relations, so that the acute experience seems to be associated, not necessarily causal, but associated with the clinical outcomes. And when we look at that across the different trials, so our trial where we compared psilocybin with escitalopram, but also the Small Pharma's DMT trial, both depression trials, when we look, it's pretty similar. People who had a high degree of a mystical experience or emotional breakthrough, they have greater antidepressant response in our escitalopram versus psilocybin trial, and similar, but it doesn't come significantly through with EBI, but complete similar pattern with significant findings with the MEQ. Same story. So it's sort of confirmed in these trials as well, that there's this relationship. And this is just that I won't go into too much detail with. This is just an attempt to create a little bit of an overview of where approximately the field is in regard to the mechanisms. There's interesting work preclinically with neuroplasticity with psychedelics that most of you have probably heard about. I'm sure there'll be other talks in the conference about that. We are trying to explore, and so are others, with in the humans using different kind of imaging techniques. We have markers related to synaptic density that we can look at, and we are doing that with ketamine. Now we are starting with DMT, and also EEG paradigms tapping into plasticity that we are also implementing in all trials, and we have more and more data on that. Then there's some anti-inflammatory data. There's a lot. This is just one example. And then some of the things that I already mentioned, I actually didn't mention, I think. We have increased connectedness. We have avoidance turning into acceptance. We have data on that. We have trade openness being increased in some trials after psychedelics. We have cognitive flexibility and psychological insight being, oh, damn it, I keep on getting some of these errors wrong. Going up. Pardon me. And I have done that mistake before, and then I changed it, but then I seem to get the wrong version again. Apologize. Negative cognitive bias, that's correct. I think that was the one that was going the wrong direction last time. I don't know how it goes wrong. Sorry about that. And then some of this that I won't go too much into. I think I'll focus on the Richard Dawes paper in Nature Medicine that was from 2 separate depression trials. The one I showed you from Imperial, where we can look at a global functional connectivity measure called modularity, and we can see. So now I said in depression first, this is the only trial we have done in psychedelic naive healthy people. So when we look at this modularity, global functional connectivity measure, we can see that the decrease in modularity, which is an increase in global functional connectivity, is associated with the increase in well-being in psychedelic naive healthies. That data is on its way. And that's quite interesting in the context of what we have seen in depression. 2 separate independent trials that you heard about earlier in the talk. We can see decrease in modularity pre to post psilocybin. And remember, this is no longer acute. This is actually, in one trial, is 1 day after we had the imaging. In the other trial, is 3 weeks after. And it shows the same pattern, decrease in modularity, increase in global functional connectivity. And we can see that that decrease in modularity is related to the therapeutic outcome. And when we look at the escitalopram data in that study, we don't see a change in modularity, and we don't see a relation with therapeutic outcome. We also see differences between SSRI, escitalopram, and psilocybin in terms of emotional phase response in the amygdala. We see that we have a reduction in response with the SSRI condition, and we do not see that again. Again, speaking into possible different mechanisms. You have that may potentially blunting emotionally and in how you deal with emotional content in an SSRI condition, and you don't seem to have that with psilocybin in a lot of ways, with a lot of measures I showed, in the contrary direction, actually. Then I think I'm probably 2 minutes. Oh, perfect. So just a note on microdosing, and I'll be in a panel in half an hour where we are going to talk about citizen science. I'll be speaking more about it there, so this can be a teaser. But basically, the only thing I would say at this point is that it's not homeopathy. That's for sure, because there is proper occupancy. The doses people are using are proper pharmacological doses. So therefore, theoretically, it could work, which is a good start. But when we are, so in the context of depression, which is the topic of this talk, if we look at all data ever collected that has anything to do with microdosing that has been published, that has to do with something relevant for depression, which would be affective symptoms, anxiety, depression, well-being, and so on. So what we did was we took the entire literature of microdosing, and Laura has been involved in this work, and we are hopefully relatively soon finished with the first draft of the paper. So this is, and there's a poster by Alexander Wingert on what I'm going to show in a moment. So what we did was we then went in and color-coded whether you had data in the paper significantly in support of benefit from microdosing, or if negative, then it would be red. And no color if there is just, it's not really going anywhere statistically in the different papers, okay? And then we separated into 4 different themes. So one of them was affective symptoms. That's what's interesting for this talk. And then we plotted it into the hierarchy of evidence. And that's what, so this is difficult to see, but the most important for you is to focus on the colors. Overall, this is pretty green. Do you agree? Pretty green. So that means supportive of effects of microdosing. This is not a meta-analysis, but it's the closest you can get at this point due to the heterogeneity of the data in microdosing. So basically, this would support that maybe microdosing actually does look like it works for affective symptoms. The issue is that this is the hierarchy of evidence. So the more you move up towards meta-analysis and do randomized trials where you have a placebo condition integrated, which you have up in this part of it, you see that the colors disappear. So that is basically suggesting that if you search the literature and want microdosing to work and find evidence for it, and you look in the bottom of the hierarchy, you will conclude that microdosing works. If you move up, you will lose confidence a little bit. So just to get the complete picture of psychedelics and depression, I think that microdosing is important to keep an eye on, and just so far that it depends on how you assess the literature and evidence and strength of evidence, how you conclude. This is not the final version. I can see some people are taking pictures, which is fair, but just beware that it's being triple checked at the moment, because it's quite complex what sits behind all these stupid little Christmas tree balls on the tree. So people are triple checking it. So if you don't share it too much, because we're going to come with the final version in the near future. So basically, I'll just say one of the reasons why this happens, no, now I am over time, is that that yes, it does improve amazing, great results with microdosing, but when you have a placebo condition in, it also helps. And it really helps if people think they take a microdose and when they take a placebo. So we can see that the effect of guessing wrongly that you took a microdose is 10 times higher than actually taking a microdose. So it's very driven by what you hope and think, and therefore expectancy effects, which also was what Laura in her paper suggested without a placebo condition. So, so that might be the reason why you have that confusing story in the Christmas tree of evidence with microdosing. So this is, yeah, thanks a lot. I'll stop here.
Thank you, David, for your great talk and collating all this quite complicated data. Now we have room for some questions. Yes.
David, there is preclinical evidence that there may be an antidepressant effect of psychedelics even if you block 5-HT2A receptors. Are you aware of any clinical trials that are sort of testing that setting?
No, and that could maybe be some 1A and other mechanisms if there is an antidepressant effect of after blocking the 2A. That's, I actually don't think that anybody is doing that work, but really quite interesting to do. So, yeah, no, I don't think anybody is doing it. I haven't heard about or seen that people are doing that. It's obviously interesting. As you heard from Matthias, you have that, blocking of the 2A. You even had, I think also from the Basel lab years ago by Comiter, that you saw that the mood improving effects in healthies were also somewhat blocked by the 2A blocker. So that's the closest I can get, but that was not in depressed patients.
Okay, next question.
Hello, thank you for that talk, David. So I was curious how much pre-dose preparation there was, and do you have any intuition as to whether this may be different in need or quantity than psilocybin? I'm thinking about the Yale IV DMT study in depression that had, I think, very minimal to no preparation.
Yeah, so the people doing the preparation, at least on the London side, so you're speaking about the small pharma, the DMT trial, right? Here, that's what you're asking for, yeah. So they are Graham Campbell and Michelle Baker-Jones, who are one of the strongest and most experienced people that have been working at Imperial. Then they were the ones hired to do this trial. So they were seeing most of the patients in the trial. So they are really, really, really good and experienced and very present and holding space and so on. So they had really good people in that trial, I would say. How much they exactly did, let me think. I think it was a couple of preparation sessions they had. I don't think that different from, for instance, Compass psilocybin trial. Quite similar.
Yes.
Is there any evidence on the microdosing on how much people are taking? Is there any indication of how much medication they're taking when they microdose? And I'm asking that because with microdosing becoming so popular and being so publicized, especially in the US, can that harm the effect of using these medications clinically in the future?
So whether there's a concern about mixing normal psychotropic medication in mental health with the
How much psilocybin or do they take when they do microdosing? What constitutes?
Oh, what doses people are using for microdosing?
And is that going to change the possibility of legalization and use of these medications, of these psychedelics for treatment?
So first of all, that's a lot of things in a way in the same topic. I think, so people are doing ranges, so it's and often slightly random. And people, if they are very thoughtful and, then they would titrate themselves up to where they feel it and then go a bit back down. That's the typical practice. And that obviously will be different because people will have a different threshold of detecting it. So that means that people are microdosing with different doses. And pharmacologically, they are not microdoses, they're mini doses because they are up in the range where they have 20, 30, even sometimes 40% occupancy on the 2A receptor. We know that from PET work. So that means it's actually doses that are pharmacological. It's not microdoses, it's mini doses, and it's a range. Whether microdosing has a different path and route through the regulatory system, if that's, I really don't think so. In order for anybody, any authorities to give approval and license, that's one thing. Another thing is whether you change the law and just make everything legal. I don't think that will be done for microdosing separately. It will be do it for the drug. Let's say you say psilocybin is legal in Oregon, go ahead, then it will affect both full and small doses. I don't think there will be a difference that anybody would allow small doses. It would also be completely odd, because if you look at the data, the evidence is really quite poor for effective microdosing, so it wouldn't make any sense. It might be safer, but it also might be less safe, because if you're doing it 3 times a week for 10 years, is that safer than doing 2 or 3 doses in a year in a full dose? Maybe not. It could be that the 2B receptor in the heart could be affected, and that is still an open question for microdosing.
Okay, thank you. We have room for one more short question. I think you.
Are there any patterns emerging as to for who psilocybin works better than normal SSRIs?
The trials we have are a bit too small to really deep dive, and that's also why real-world citizen science data that we'll be talking about in the other session is interesting, because you can get cheap, quick, up in numbers and explore some of these things in a more dirty way, but still with a lot more data. So obviously it's an interest of all the companies, all the academic groups, to try to look at measures of what predicts what. You saw some of the pharmacological things, lichty, genetic, poor metabolizer, all that should also play a role, because it will have a role of the plasma levels, therefore also the subjective experience, because there's relationship there, therefore also onto therapeutic outcome. So that's one example of something we will be understanding more, like Matthias will, and then the rest of us will after, when they have done the work. I think they're the main one doing this kind of work, which is important. Then you have psychological factors. We know some things about readiness to surrender. You see, if you have very high neuroticism, you might have high likelihood of having a negative effect. There could be some ceiling effects and some personality measures. We are also trying to look at complexity in the brain acutely using EEG and see whether we can start predicting and how we associate that with the subjective experience and the later outcomes. So a lot, both biomarker with imaging, but also psychological measures are being looked at, but you need quite big numbers to look at that many things in a small, when you do that in a small group, patients, people, it's complicated. But it's in everybody's interest, and there's a lot of work being done to try to predict who respond how.
Okay, thank you so much, David, for your presentation today. And now we have a break until 11, and then we will continue.